So very good morning and welcome to this wonderful Refractive Subspecialty Day program. So cruising on to the session 2 of this would be the Excimer based refractive surgery. And with me, Dr. Mohita, Dr. K.P. Kudlu and Dr. Ajay Sharma will be chairing. And I have Professor Dr. Rajesh Sinha who will be moderating this session. All to you, Dr. Rajesh.
A very good morning to all of you, and thanks to the scientific committee for this wonderful opportunity. We begin with our first speaker. We have, do we have Dr. Harshul Tak here? Okay, he is not here. Then we will have our first speaker, our chairperson, Dr. Sonu Goyal, who will be talking about femtolesic basics.
A very good morning, and without wasting much of time, I thought Harshul would lay the stage with the basics of microkeratome flap making. So I've been asked to talk on the basics of femtolesic by Vardhman. So a very brief initial picture of how the femtolesic procedure works. So essentially we have this, it's basically the YAG laser operating in the infrared wavelength, and it produces these ultra-short pulses of energy. And this creates ultra-short pulses of energy, and this basically creates areas of microcavitation. And this essentially leads to separation of tissue at the molecular level and at a very specified depth of the cornea. So the bubbles which are created, they leave a cavitation bubble volume of around 2 to 3 cubic microns, and thousands of these tiny bubbles create in a raster pattern, and this is essentially what creates a cleavage plane, and this defines the interface between the flap and the stromal bed. So this is how the femtosecond laser actually works, and then you do an excimer ablation and keep the flap back. So essentially most of our practices have now actually shifted from microkeratome to femto-based flaps. So this is how we treat, and this is how I use the 800 platform. It takes essentially 5 seconds. You can center the flap, just watch carefully, and it is just a blink of an eye that this, once you dock, and this is how the flap is created. The laser system now moves free to inside, and then you have a side cut, and this is essentially the game for the flap creation. So this is how the main page of the VisuMax Smile 800 looks. So when you're talking of the flap with the femto platform, this is essentially a planar flap. So if you see here, vis-a-vis the meniscus shaped when you do a microkeratome based flap procedure. So what are actually the parameters which can be altered or they can be titrated when you're doing a femto-based platform? Now this is very, very important. These are the K readings which can be entered, the pachymetry. The treatment can be centered. So with the X and Y coordinates which can be taken on a topographer, the atlas very specifically here, the treatment can be centered right bang onto the visual axis. The flap can be taken on the visual axis. Then you have the refractive error, which doesn't essentially give you, not required. So the flap parameters which can actually be titrated vis-a-vis the microkeratome is the diameter of the flap here. You can have the thickness varying from as low as maybe 90 microns to whatever depth you want. The side cut angle, which is very, very important because this is one of the factors which helps in the epithelial ingrowth, can be titrated. You can have the hinge position which can be titrated. It could be a temporal or a superior or an inferior or a nasal hinges. So essentially we are talking here the nasal and the temporal hinges here, and the hinge position, the hinge angles, and the width of the hinge can be titrated. So these are the essential parameters which, when you're dealing with a femto-based platform, can be titrated vis-a-vis the microkeratome structure. There are certain essential benefits when you're doing a femtoflap. It basically gives you a good visualization of the stroma. So that means whenever you're doing, and once you have docked, you essentially see where you are cutting. So even if you have a suction breakdown, you can see at what level or what percentage of the cut has been, and then you can restart the treatment. You can customize the flap parameters. I'll be talking about this. So customization means you can actually vary. You can have a nasal or a superior hinge. You can, as I told, the diameters, the thickness, and the side cut angles can be customized. So the side cut angles can be customized, the flap thickness can be customized, the diameter and the centration can be customized. So sometimes for patients where there is an angle kappa you're talking about, you can actually slightly decenter, or you can make an oval. You can have the selection of the hinge and the flap orientation. And, but this is the independent of the suction ring location. Now, when you are talking of the microkeratome vis-a-vis the femto, there are fewer flap-related complications, as in what we normally see in a microkeratome. A lot of chances of incomplete flap. You can have buttonholes, free flaps, irregular flaps, and the hinge position flexibility is one very important thing. And this ultimately boils down to epithelial, less chances of epithelial ingrowth. And when you talk of mechanical blades, sometimes you can have the malfunction because of the loss of the power. We have seen a lot of times the mechanical parts get jammed. There can be a loss of suction. You can have improper assembly when your assistant really makes your day hell. Clinically insignificant, but when you use a femtosecond laser system, so I mean, actually, all these complications boil down to a very low incidence when you're talking of the femto-based platform. Now, the hinge position flexibility is actually very important because you can customize the hinge position, because patients, when we are dealing with high regular astigmatism, you can actually have a superior hinge to have a deeper ablation, which is required in the 3 to 9 o'clock. Dry eye, a lot of studies have seen that they may benefit from nasal or a temporal hinge position due to decreased severing of the afferent nerve trunks. Hyperopic patients may benefit from the temporal hinge position due to the nasal angle kappa. So the femtosecond laser actually stands advantageous. And a lot of studies have shown a lower incidence of epithelial ingrowth, and this is essentially because of the side cut angle. So you can actually customize the side cut angle, and it is believed that with this actually locks the flap and the side cut, so which inhibits the passage of the epithelial cells into the interface. There is less variability in the flap thickness. So the standard deviation with the femtosecond is close to around 11 microns as compared to mechanical, which is close to around 14 microns. You can actually control the flap diameters and the hinge width. And it is found that the higher order aberrations when compared with the mechanical microkeratome is slightly less, and which suggests and translates into an improved visual outcome. It's not that this system doesn't have disadvantages. There are a lot of disadvantages which can occur. You can have opaque or the OBL. You can have vertical gas breakthrough. And you can have sometimes patient complaining of transient light sensitivity syndrome, which could last for a couple of days. You can have a high rate of DLK in patients, and definitely the higher cost which is involved for the purchase and the maintenance. A lot of studies worldwide which have compared, but all of these studies have basically essentially boiled down to the microkeratome-based systems. So I'll just take a minute more. So all of these studies have essentially highlighted that most of these complications that occur in flap making are more with the microkeratome based as compared to the femtosecond, and essentially the free caps, the incomplete flaps, buttonholes, thin and thick flaps, irregular flaps, suction loss, essentially are more with the microkeratome based systems. So femtoflaps on the ASOCT, a lot of studies have said were more accurate, they were reproducible and uniform than those created by the microkeratome, though both the femtosecond and the microkeratome LASIK are quite effective and safe. So there's no statistically significant difference in the uncorrected and the corrected visual acuity, though the FS scores over microkeratome in terms of the predictability of the flap thickness and the fewer induced higher order abrasions and the better contrast and the longer tear breakup time. So when you talk of the ocular surface changes, the femtosecond laser allowed for a full recovery of the tear meniscus as compared to the microkeratome, which failed to reach the preoperative levels. So to conclude, the femtoflaps on the anterior segment OCT are more accurate, they are more reproducible, and they are more uniform than those created by the microkeratome, though the vision and there is no statistically significant difference in terms of the vision achieved. So a lot of references which I would like the people who are new to the system to read this, and a lot of literature and work has been done. So thank you very much.
Thank you, Dr. Sonu, for a very nice, overview on the basics of what is femto-LASIK. And we all understand that there's definite advantage of, femtosecond laser in creating the flap, because the flap-related complications have really gone down. And in earlier generations, I think maybe OBL was an issue. These days, it's hardly an issue. A major issue is the cost. Microkeratome also does well, but in a large percentage of cases wherein you have a very steep cornea or a flat cornea, in such cases, there's definite advantage of femtosecond laser. And what I feel, although there's no comparative study to my knowledge, but I feel that the edge of the flap somehow also to some extent prevents the increased risk of epithelial ingrowth in these cases. So that's definitely there. Any comment or any, Dr. Ajay, can you please come up? Any comment or any addition to what Dr. Sonu has very nicely pointed out? Yes, sir.
I think there's improvement in every field, everywhere. Even microkeratome has improved in between. We are now getting planar flaps, which are much comfortable, and we can have a overlap also. Of course, femtosecond has advantages, but these things are also improving.
Yeah, that's very true, sir. Very true.
But sir, I'll just like to interrupt in this. Actually, in your practice, you would have noted whenever you're treating patients who have actually a very flat cornea or a very steep cornea, when you take these patients on a femto platform, you're hardly concerned about the K readings. But actually, when you take these patients on a microkeratome-based system, you're actually very conscious that you might end up whether in a free flap or a buttonhole. So whatever the improvement might be, but still, that kind of, some kind of dilemma in the mind always remains, and you are a little extra cautious. So I think it is these extreme of patients which are essentially very important when you're dealing in such subset. The only indication I still feel is those patients which have a scarred or a corneal opacity where the femtosecond actually cannot penetrate. So I think this is one essential indication I would, boil down to microkeratome-based flap system.
Yeah. A very faint scar, it still works, but if it's a dense scar, it doesn't.
Thank you.
Thank you, Dr. Sonu. We have our next presenter. Complications management is very important in the flap. So, Dr. Rajesh Sinha, we all know him. He is an excellent surgeon and excellent person. He'll be talking on top 3 flap complications and management. Dr. Sinha, please.
Thank you, Dr. Ajay. The topic that I was given was top 3 LASIK flap complications. Well, it was difficult to decide which are the top 3. There are so many. But then I thought that I'll focus on flap buttonhole and, of course, flap stria and epithelial ingrowth, which can happen because of various factors related to the flap. And so flap buttonhole more often is seen with a microkeratome where there is a buckling, as was being discussed by Dr. Sonu, that in a very steep cornea you can have flap buttonhole. And it's a very old video of flap buttonhole wherein we did have this thing in a steep cornea. If you have a flap buttonhole, you have to defer the surgery and do a recut. Later, you can do a microkeratome LASIK in this with a larger cut and going deep, and or you can do a surface ablation as well if you want to do it a little earlier. Femtosecond LASIK, in that also you can have a vertical gas breakthrough, which is very uncommon, but yes, it can happen. In that case, again, you have to wait for a couple of months, and you can go ahead and do a surface ablation easily with in all these cases. So I'll just move on to the next one. The next is flap stria. Now, flap stria can be seen if you are ablating quite a lot, wherein again, what happens that you tend to keep a very thin flap, and in such cases, the risk of flap stria is there, particularly when, sometimes when the patient rubs the eyes or there is some trauma, etc. In that case, it can happen. Now, if you have a flap stria, then you have to refloat it. Do an ironing. But whatever you do, I think ironing, etc., it does help. But what in our clinical practice, and I think even in studies, they've shown that unless you, debride the epithelium and swell the stroma of the flap stria don't disappear in large majority of cases. Maybe on day one, if there is a flap stria, you can just refloat and it can go off. But if you have a case wherein, it's a 1 week old, etc., then in that case, you have to debride the epithelium and hydrate it with hypotonic saline, or if you don't have hypotonic saline, you can use simple distilled water, which is there in every operation theater, and that swells up. The idea is to swell the stroma of the flap so that the flap stria disappear, and it works very well. Sometimes you can have a trauma, like in this case, the patient had a trauma, and then you can see the flap from here has moved, so it is a dislocated flap with flap stria, and there is epithelial ingrowth as well. As you can see in this photograph, there is presence of epithelial ingrowth. So in such a case, again, you have to lift the flap, and once you lift it up, debride the epithelial ingrowth, whatever is there. And then, of course, one should use mitomycin C in all these cases, because you cannot be 100% sure that all the epithelial cells have been removed. So it is essential that you should use mitomycin C 0.02% for 45 seconds to 1 minute, depending upon your choice. You can do ironing of the flap, and then once you have done, you can do ironing, and once you have done that, you debride the epithelium, put some hypotonic saline or distilled water on the surface so that the stroma of the flap swells up so that it stretches, and that's how it takes care of the flap stria. This is the post-op picture. There's no flap stria in this. Epithelial ingrowth is another very important issue which can happen because of improper flap, because of various reasons, because of the flap dislocation, because of in hyperopic LASIK it is more often seen because the ablation is in the periphery, so the flap edge apposition is not that great, so that is possible. You can see here you can have a very small epithelial ingrowth. The area of entry is here. Here, if you put a small drop of fluorescein, you will get a stain, and that shows that the adhesion or the apposition of this flap at this point is not good, and that is why epithelial has gone in. You can have a bad epithelial ingrowth which is in the center. This was the epithelial ingrowth in the center, not coming from the flap edge. So we were just wondering why it happened. It happened because there was a flap buttonhole. You can see there's a thin scar here at the edge from where the epithelium is going in. The incidence is not very common, and with the femtosecond laser, the flap edge, if you create a good flap edge, the risk of epithelial ingrowth is not very high. But in cases of EBMDs, like epithelial basement membrane dystrophy, you have higher chance in case of diabetes, wherein whenever there is risk of loss of epithelium, the risk of epithelial ingrowth is high. As studies have shown that it's very high in hyperopia. And once you have an epithelial ingrowth, you lift the flap, and then you debride the epithelium, put mitomycin C, as I showed in earlier picture. But sometimes you can have a very bad epithelial ingrowth, which, if you see in this case, this patient was operated 11 years back outside this country. A prisoner came to me with this much of epithelial ingrowth. And when we did AIOC2024, we found out that the epithelium was actually entering into the flap. It was difficult to remove it from the flap as well. And if you debride the epithelium, just debride it, it is, whatever you do, it will come again. In such cases, flap amputation should be done, because the risk of recurrence is very high. And with flap amputation, the only fear that people have in mind is that how much will be the refractive error? It is not much. In most of the studies and in our own experience as well, the hyperopia is hardly anything. You can get little bit of astigmatism, mainly more often because of the microkeratome flap, because in such cases, what happens that if there is any surface irregularity, the interface irregularity is also there, and that can result in some astigmatism. So you do a flap amputation, and I'll just move fast because of paucity of time, and then use mitomycin C. And this is the post-op picture. It's clear, and the patient has plus 0.75 diopter sphere and plus 0.75 diopter cylinder, and he is 6'6". Now, as I showed in one photograph, this was a case of a flap buttonhole, wherein you can see the epithelial ingrowth has not come from the periphery, it has come from the edge of the flap buttonhole. And then in that case, you have to lift the flap, and once you lift it, as you can see, I'll just show, this is the edge of the flap buttonhole. You can see it's coming out, and then you can, even after a very long period of LASIK, you can still lift the flap. But in such a case, if you have a flap buttonhole, it's better to amputate the flap, because if you replace the flap, it is not going to help at all. Again, there will be epithelial ingrowth. So I'm using alcohol, debriding the epithelium, and then with the help of a lamellar dissector, this island of stroma has to be removed. Now I'm just removing the epithelial ingrowth, and with the help of a lamellar dissector, I'm removing this island of stroma. And once it is removed completely, put mitomycin C, and then put a bandage contact lens after washing it thoroughly. So studies have shown that the results are good. Just 30 seconds more. This is a case wherein there was epithelial ingrowth in the periphery. There's a standard teaching we all follow that if it's in the periphery, don't do anything unless it is causing high astigmatism, unless it is creating problems. And in this case, there was a flap melt because of the elevation of the flap because of epithelial ingrowth. Then again, flap amputation was done, and in this case, I have done a superficial anterior lamellar keratoplasty in this, replaced a similar thickness of donor lenticule. But doing both, what I have noted is that even if you do a flap amputation only, there's hardly any refractive error. So in conclusion, LASIK flap complications can be seen more often with the microkeratome and also with the earlier generation of microkeratome, more often seen with any abnormality in the cornea, if it's very steep, very flat, hyperopic LASIK, etc. And depending upon the situation, we have to manage accordingly. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. You talked about flap amputation. So is there any limitation to the thickness of the flap where you can amputate, or maybe some thin flaps can be done?
See, most of the times these complications, like the flap buttonhole that was there, it was a thin flap only, and it can be amputated. But most of the times, these days, we hardly create a flap of 100 micron or a 90 micron or 110 microns, even if you are using femto or you are using microkeratome. So if you remove that flap, if you amputate the flap, it doesn't cause, actually it has been seen in studies also, and we have also noted that it is not the mathematical calculation that if you remove 100 microns, it will be about 100 divided by 15, and that much of a refractive error will be there. Most of the studies have shown that it is plus minus 1 diopters, 1.5 diopters, not more than that. Just one point has been noted, that there is some degree of astigmatism, particularly in microkeratome LASIK. Why? Because they have shown that probably the interface is slightly, there are some crypts and some elevations which are compensated when you put the flap. Right. But when you remove the flap, those crypts and elevations are exposed, and that is why you get some astigmatism. And invariably, most of the cases, or all the cases, you get some astigmatism, but that is also about 0.75 or so.
Thank you.
So, thank you, Rajesh. Just a quick question for the benefits of the audience. So what is the concentration of mitomycin C and alcohol that you would advocate in patients with epithelial ingrowth, or which is your preference?
Alcohol I use 20% and mitomycin C 0.02%.
And what is the duration?
Alcohol, when I'm using for say PRK etc., I will use it for 30 seconds. But when I'm doing it for an epithelial ingrowth, I'll use it a little longer, maybe 45 seconds. And for mitomycin C again, I will use 45 seconds to 1 minute.
Okay, thank you. So next we have Dr. Harshul Tak. He's a prolific phaco-refractive surgeon from Rajasthan, and he'll be talking on microkeratome LASIK, basic and role in 2024. All to you, Harshul.
Thank you so much, Dr. Sonu and entire AI scientific committee for giving this opportunity. I'll be speaking on microkeratome LASIK basics and relevance in 2024. So if anybody is thinking that what is the scope of microkeratome, let me tell you the industry forecast that by 2030, the microkeratome market size will be $1.3 billion. I can't make out how many Indian rupees is that. So there's a huge market. We all know that 70% of the surgeons, they are still using microkeratome LASIK, and recent Cochrane review in 2020 found there's no difference in visual acuity outcomes between femtosecond laser and microkeratome LASIK. So quickly going through the history, we all know it was Jose Bereker in 1958 who started keratomyelitis, and in 62 he developed manual microkeratome. It was Trokel and Srinivasan in 1983 who they found out the corneal application of Excimer laser. And finally in 1990, Pellicaris who started using the hinge technique in LASIK. So as Dr. Rajesh said, that from the older time, the microkeratomes have advanced, and now we have advanced microkeratomes. And so the basic principle of all the microkeratomes, whatever company microkeratome we use, that there is a high precision oscillating blade system which is there. And this system, it docks to a suction ring, and which creates then it creates a lamellar corneal flap in the cornea. So basically microkeratomes, they either use a translational motion system, like in SBK, Moria SBK or Amadeus, where we create a nasal hinge, or we can use a rotational type of system like Hansatome, where a superior hinge is created, or either a nasal hinge can be created. So quickly looking at the component, so can I have a pointer please here? Yeah. So we have a console here, so which is the central unit, and so there is a motor and microkeratome head, and there is a suction ring which fixates the eye. So there is a suctioning, and we have foot switch so that we can create the vacuum and we can progress the motor forward for the pass. So this is the central unit which delivers the energy needed to drive the motor of the microkeratome, as well as its suction ring is connected here, suction tubing, so that when we need to fixate the globe, it creates a suction. So, and this is the drive unit which is there in this, this is the Moria microkeratome. And this is the microkeratome cutting head. So now all these keratomes, they have disposable, this cutting heads here. So this is the non-vibrating block here, and there is a oscillating blade. So it is basically based on the principle of Carpenter-Rando, that when it moves forward, it creates a lamellar flap in the cornea. And there is a suction ring, which is via silicon tubing, it's connected to the central console. So the sizing and the stop of the suction ring depends on the horizontal keratometry of the eye, and we should always strictly use the nomogram given by the manufacturer. So this is the nomogram. I use Moria SBK microkeratome. So this is the nomogram which is given by the manufacturer. That I give you an example that if we have a K of 43, so if you have a horizontal keratometry of 43, we have to use ring of size 1, and stop is decided depending on whatever stop is given, 7.5. So if you have a diameter of the cornea which is greater than 12 millimeter, it's a larger diameter cornea, we need to use a ring which is smaller, value, that is ring 0, which is thinner. And if the diameter of the cornea is less than 12 millimeters, we have to use ring which is 2. That's the upper higher ring we need to use. So which is, all these things are given in this nomogram. We should always follow this nomogram, and we should always center the suction ring on the limbus. Don't try to decenter the suction ring. So after that, as I said, there are two types of systems. This is the Amadeus and the SBK Moria system, which makes a linear flap. So advantage in this kind of system is that when the flap is making, you can clearly see the flap which is being made here. So in cases, if you have a flat keratometry readings, if there are chances of free cap, you can easily see that yes, you have an entire flap in near the blade, and you can safely preserve that flap, and after ablation you can place it again. Whereas in the rotatory system like Hansatom, you can't really see that what's happening down below. So this is the Hansatom or charazopendular keratome. So as I said that nowadays almost everybody has moved to the SBK microkeratome, that is a thinner flap LASIK. So the advantage of this is that the flap which is made is around 100 micron thick, and so if we have a thinner flap, it preserves the biomechanical strength of the cornea, so decreasing the risk for corneal ectasia. And refractive and visual outcome SBK are also found to be comparable to or better than standard LASIK, because there is a faster visual recovery, better predictability, better contrast sensitivity, and lower rate of enhancement. And moreover, because of the thinner flap, we can get the more amount of myopia which can be treated. So advantages, as I said, of microkeratome is that its operation, it only takes 20 to 30 seconds as compared to femtosecond laser, which takes longer time. And because the operation time is short, suction duration is short, it allows patient to be more comfortable. And moreover, microkeratome LASIK, it causes less inflammation as compared to femtosecond laser. Chances of DELC are less in microkeratome. And it, of course, costs much less than femtosecond laser. So this is a study which compared the older generation microkeratome, Moria M2 microkeratome, with the SBK and the femtosecond laser. And this study found out that the flap thickness was more predictable in SBK and femtosecond group, with insignificant difference between intended and achieved flap thickness, whereas in the older generation of microkeratome, the difference is higher and statistically significant. If we look at the, so there are some complications, of course, which can happen with microkeratome LASIK, but if you look at the statistics, it's only 0.6%, with femtosecond it's 0.3%. So most common complication is the epithelial defect, which is caused by the shearing force. And there are other complications like free cap, buttonhole, which Dr. Rajesh mentioned about these complications. So I'll quickly show a short video of this. So it's very important to put the marks which are asymmetrical. So here I place 2 marks here and 1 mark here. In case you have a free cap, you can easily align the flap to these marks. So after that, you just put this suction ring there and build the suction. So suction has to build more than 65 millimeter mercury. So there are few clues which tells you that adequate suction has been achieved. First is, of course, pupil transiently dilates. Secondly, patient sees the light getting dimmer. And third, you can always check it with the intraoperative, this varicoid tonometer. So this is a flap which is made with 1 pass. As you can see the flap here. And once you remove this suction ring, just 30 seconds more. So you just lift the flap. And after that, you do the stromal ablation. And once the stromal ablation is done, you just deposit back the flap. And just let it dry for 1 to 2 minutes. And once it's dried, the case is over. So we have advantages with microkeratome LASIK that it has a proven record. There is lesser cost of surgery, reduced surgical time, less inflammation, and can create flap in anticondylar opacity scars also. Thank you very much.
Thank you, Dr. Harshul, for presenting something which large majority of people are doing. And yes, microkeratome is very useful. Only in very steep or flat corneas, there may be some risk. And the only minus point is that, I mean, it is not under direct visualization as you can do in femtosecond. But otherwise, it does its work in almost, I mean, large majority.
But with SBK,
with almost similar efficacy. Yeah, yeah. Thank you. Yes, Vanashri.
So I have a doubt, like to all the panelists. If we have both the platforms available, I have microkeratome as well and a femtosecond laser as well, and if the cornea is steep, at what level should we take a cutoff? Like, and if it is beyond 45 or 46 cornea, should we prefer femto instead of MP?
Yes.
What should be the cutoff for a surgeon that you should think?
Anything which is steeper than the normal. I mean, if you consider, 42.5 and 43.5 as normal, and say, suppose it's more than 44. I mean, if you have the femtosecond laser, why don't you use femtosecond laser?
I have done till, I do till 48 microkeratome LASIK without any problem.
Actually, above.
And in flatter side, 40. 39 also I've done. But free cap is not a major problem. Of course, the steeper corneas, buttonhole is of course a problem.
So sometimes the cost is an issue, like patients are.
Then more than 46 is my criteria. I keep that if it's, I mean, we have switched over completely to femtosecond, but when it was both, we were doing both, then my criteria is more than 46. Would like to have opinion of panelists that if it's more than 46, I would prefer a femtosecond laser rather than microkeratome because of the risk of flap buttonhole.
I do up to 48 also. I got a old microkeratome from Amadeus 2. Actually, it works on the keratometry reading, and depending upon that, we can adjust the hinge. But that microkeratome last 10 years is not available in the international market. With that, according to them, you can go up to 48, 49 also. I have done, and I never faced any buttonhole.
No, the question is not that whether you do or not. The point is that whether there is any risk of flap buttonhole or not. That is the point. So, I mean, it is doable, but the risk is
with SBK microkeratome, I still do till 48. I didn't have any of the flap complications.
For the sake of the the audience, 46 should, for me and most of us, 46 should be the line. Yeah, because we can do many things, but there are certain stunts which cannot be tried at a general level. So please, I think 46 should be a safe.
I think most of us now shifted to femto only.
Yeah.
So question of.
So our next speaker, with the permission of Dr. Bhaskar, Dr. Samresh, and Dr. Diksha, if they permit, Dr. Kudlu has to go to this other session, so we would like to speak first. So if it's okay, then he'll be presenting on post-LASIK refractive error. As such, also, he's the chairman of this session. So,
thank you, Rajesh bhai. Thank you, Ajay, for the kind introduction. I excuse myself. Can you switch off my? Yeah. Actually, I'll be talking about something complications of advanced surface ablation and management. No financial disclosure for this talk. So what are the common complications it can come across? One might be having a delayed epithelial healing, post-PRK haze. You may have a decentered ablation with irregular astigmatism. And of course, one of the dreaded complications is infectious keratitis. So coming to the why there is a delayed healing, because sometimes what happens with the uneven removal of the epithelium, and sometimes even with the larger zone. And the other causes like over usage of steroids and non-steroidal anti-inflammatory drug. Patient might be already having a very severe dry eye also. And even it can happen in patient with immunocompromised patients. And also improper irrigation following alcohol and also MMC application. So coming to the management, it's very simple. If you are putting them on non-steroidal anti-inflammatory drug, stop there. Then quickly you taper the steroid. Even if it is not responding, sometimes autologous serum is not a bad option. Put plenty of lubricating, that means hourly or half an hourly. And very important during the pre-operative step, that avoid excess use of mitomycin C during the procedure, and if you use also, you need to have a thorough irrigation. So coming to the decentered ablation zone, normally this center of ablation does not correspond to the optical axis. So glare, halos, even ghost images and blur vision can happen. So why this decentered ablation happen? Because of the one reason, poor patient fixation, poor patient instruction. Very important to note about the large angle kappa. It can even sometimes happen in a patient with over anxiety and even with over sedation. Sometimes when you are doing with the Excimer, you may lose the eye tracking. That might be the major cause. So coming to the if you are having a decentered ablation, when you are thinking about diagnose, always patient will have a reduced best corrected visual acuity. Also, you can see in the tangential map, we can see the decentered zone of ablation. Of course, there will be definitely increased higher order aberration on aberrometry, especially you will have a more coma. And also, if you do autorefractometer, then whatever the cylinder it gives, which might not be correlating with the manifest cylinder. So coming to the treatment, if the decentration is around less than 1 mm, patient is not too complaining, then best to observe. If the decentration is more, like suppose more than 1 mm, then if the patient is having significant visual symptoms, then proceed for the treatment. This is a small chart I am just putting you. Even people tried with the contact lens trial, if you see that there is improvement in the symptoms, then you can continue with that. But if the patient is not willing, then you should plan for either a topo-guided or wavefront-guided treatment. So then always when you're doing, always you should look for the lenticular status, especially those who are having eye trace, no financial disclosure. Look for the dysfunctional lens index, and also look for the nuclear scan also, and also you should look for the internal abrasions. So coming to if you are having already decentered ablation zone, if the patient is having poor DLI, then if you have got a higher internal abrasion, then always you should never touch them with the Excimer laser. Rather, you should go with the lens-based approach. If you think that patient is having a good dysfunction lens index with normal higher order aberration, then I think binocular vision, even orthoptic assessment you have to do. Because Dr. Rohit Shetty is sitting here, one of the genius in refractive surgery. He always used to tell me that always for all these refractive patients, binocular testing is very important, and even with the orthoptic assessment is a very, very important test to do. So this is about the treatment. So most of the study shows that the topo-guided treatment will be much, much better than the wavefront-guided treatment. So this is about the topo-guided ablation for the decentered treatment. See, you can see there are a lot of change, like from the pre-treatment to the post, you can see which is well-centered, which is respect to the visual axis. The other complication you can see is PRK haze. Normally, what happens, there is a loss of corneal clarity, which is early or late onset, which can happen around in 0.5 to 4% of the patient at 6 months. The reason for the patient will have a refractive regression also, reduced visual acuity, and it may cause irregular astigmatism. These are the pathophysiology of the PRK haze. So there will be a fibroblast, and all depending upon how the corneal remodeling happens. So what are the risk factors for post-PRK haze? Especially high level of refractive error, more than 6 diopters, depth of ablation more than 90 micron. It can happen in patients with high astigmatism, and the type of epithelial remodel and UV exposure. So what are the precautions? I think careful assessment is very important. Intraoperative use of MMC in case of when you're doing PRK. Avoid excess UV exposure post-procedure, and medical management, especially with corticosteroid and cyclosporine. So of course, corticosteroid is the way to start with, but it may cause a delayed wound healing. There is a chance of increased risk of infection too, and even if you put for a longer period, the chances of posterior subcapsular cataract is also quite high. So cyclosporine nowadays, I think it prevents the T cell from releasing cytokines, which does not inhibit corneal wound healing, no serious drug-related event, and which is safer for prolonged use. So as the cyclosporine, which acts on the early phase of the pathophysiology, What I feel that it should be started very early, in fact, even in the preoperative stages also. So post-PRK treatment haze, short tapering of the steroid 2 to 4 weeks, then continually start the cyclosporine, continue for up to 6 months. If there is no resolution, then you can plan for mechanical scraping with MMC, or you can do TPK with MMC. So this is the last complication, that is infective keratitis because of overuse of topical non-steroidal anti-inflammatory drug. So normally early onset versus late onset. Early onset normally might be staphylococcus, or late onset might be acanthamoeba or atypical microbacteria. So the treatment short trial of topical steroid improves seen, continue the taper steroid, no improvement, then start antimicrobial therapy, then send for culture. So under correction, over correction can happen. Why under correction? Because of improper refraction, wrong refraction and improper laser setting. Management, if the patient is not complaining, epithelial remodeling sometimes may correct. If significant, plan for treatment, wavefront guided treatment. The other complication can happen like regression, ectasia and dry eye symptoms. So you need to tackle them preoperatively very well. So take home message, nowadays most of us been doing advanced surface ablation in the recent years. Because of high expectation of the patient undergoing this procedure, it is important to recognize and address potential complications. With appropriate patient selection, meticulous surgical technique and diligent post-operative care, almost any complication of advanced surface ablation can be managed with utmost accuracy, restoring the useful visual acuity. Thank you one and all.
Thank you, Dr. Kudlu, for a wonderful talk. I think surface ablations are definitely a very good technique still. So, any questions from the audience? Yeah, please.
Especially when we do the very simple test of Sherman's, if I think that the patient is already having a borderline dry eyes, then I start them pre-operative only, just a week or couple of weeks before only, then I continue them for a period of 2 months, sir. Yeah, specify. If the Sherman's is good and if all dry eye workup, then post-operatively for every patient I start cyclosporine.
Thank you. So we'll move to the next stop.
Sir? I use, sir. I use minimum of 3 to 6 months cyclosporine.
How long does it take the PRK haze to disappear, sir?
Huh?
How long does it take for the PRK haze?
PRK haze, again depending upon the patients, normally it resolves by around 3 months. If you put them aggressive steroids, it can disappear quickly also, but you need to know about the complications of steroids use also. But if you, I think, aggressively put them on prednisolone, like start with 4 times for a week, then tapering and all, even I have seen patients within 1 month they regress. But if you put them on fluoromethalone or loteprenolol, then I think it will take up to 3 to 6 months.
I've seen a patient, he has come with a haze after 6 months also, sir.
Yeah, then again you have to start them on steroid, taper them and wait.
Okay. Thank you, sir.
Thank you.
Thank you very much. We have our next talk by Dr. Bhaskar Srinivasan. He'll be talking on topo-guided femtolesic, concept, indications and evidence. Dr. Bhaskar, please.
PRK, I do up to -6 diopters. But there are few of my friends doing up to -10 also. I think Dr. Vinodhar do agree with that. Again, how you use this mitomycin C, the time calculation, then I think you can do. Again, it's depend upon the patient to patient and a lot of other factors involved in the refractive surgery. So the pre-op workup is so important. Probably and soon I think from Narayan Netral they are going to come with a biomarker kit. So if you take out the tear from fluid, then you can do the test. That, you'll get a lot of relevant points on that. Then you can just, depending upon that, you can plan whether which treatment to patient is suited.
A very good afternoon. And I would like to thank, is it coming dull? I can put this in.
I think, is there any, then who is the next speaker? I request Samresh plug in. So Samresh will be talking about topo guided LASIK, paving a strong pathway.
AV से कोई है? This one. Yeah. So again, very good morning, and thanks to AIOC for inviting me for this conference. And sorry, Dr. Bhaskar sir, I'll have to speak the same talk before you. I was dreading speaking it after you, but now I get to speak it before you. So for all of those, all of us who are doing LASIKs or have done LASIKs, we know it's very simple. Unlike a cataract, you do a refraction. Most of the investigations that we do are to rule out outliers so that we don't land up with complications post-operatively. And then we generally ablate the refraction or we take out the lenticule, and that's how a simple LASIK works. The difference in topo-guided LASIK is that between refraction, or the number that we check, and the treatment that we do, now there's a machine that picks up all the diagnostic data of the curvature of the eye, the topography, and pushes this data onto the machine, and this data, for once, is now usable to not only treat the numbers, but also to make the cornea regular and more mathematical. So I'll start with this case over here. This is one of the few cases that I did in the beginning under with Dr. Rohit Shetty at Nara Nethralaya back in 2011. So it's not like it's new, but this is what it was being used for. Keratoconus patient. I had to really fetch out this case. So this is an inferior cone, as you can see. The idea for treatment in this was not to give vision, but to halt the progression and, or more importantly, to regularize the cornea, but it had been a stable cone. So this is the topography, which shows you the cone. This is the ablation profile that is decided by the laser based on the topography data. And then if you superimpose the ablation onto the patient's cone, you will realize that the laser is going to fire in certain areas where it's going to thin the cornea and it's going to shave off the cone. So just to show you the impact of before surgery topography and after surgery. The entire coma or irregular aberration is converted into a regular corneal astigmatism, and such was the power of topo-guided treatments, or what it was called as TCAT many, many years ago. So again, to show you before and after. And again, same thing with the pentacams, showing the same thing. But interestingly, on the aberration profile, which is what matters and which is what we're looking at, a bad aberration profile on an aberrometry, you don't even have to know the machine, turns into a good post-operative astigmatism, which can be treated by many ways: glasses, contact lenses, or ICL, whatnot. So I'll just move out of this, again, to show you before and after of the same treatment. The question is, what happened?
we looked at the topography and we treated the cornea based on topography. Now, later, a few years down the line, it started coming up as what is known as contour vision or topo-guided treatment. So we all realized that what we could do with bad eyes, we could do much better with eyes that are pristine and good. Not only treat the numbers, but make their corneas better. Again, a case scenario, just to show you a 20-year-old with stable refraction, slight anisometropia, and this is the preoperative topography. Like it was discussed in the previous study, I use a mix of Placido topography with shine plug because the anterior corneal curvature comes out better with Placido. And I decided to do a contour treatment on this patient. This is how the capture looks like. You get the pupil, you get the visual axis, and you get a lot of data. This data is then pushed onto the machine, onto the Excimer laser, because it has a large number of points compared to a pentacam or any shine plug imaging, because it is a Placido. And Placido obviously has more curvatural data. This can be done by either networking or by a USB. And then you plan the patient's treatment, and you need a number of scans because you average out the scans, and then you decide what's going to be treated. So in this same patient, if you notice, this was the treatment. If I were to do a simple LASIK or a lenticule or whatnot, it would be an optimized treatment. Versus if I do a topo-guided treatment, the difference is this. Apart from removing the numbers, it's also going to shave your cornea in certain places a little more and a little less, so as to make an irregular cornea. Even in a regular, normal, pristine virgin eye, it will make it better so that your vision becomes better. And this is true customization, which is, as of now, not available with any lenticule or any other LASIK formats, which do not have. So obviously not Contour, there are certain companies that also have topo-guided treatments, but such level of customization is still not available with any sort of lenticule extraction. What other things it does is it gives you centration on the visual axis, and it also compensates for cyclotorsion, which we all know as cataract surgeons and refractive surgeons, the eye rotates when we lie down, and so the ablation should also rotate to match the eye in order to give the right outcomes to the patient. Sometimes the pupil also shifts, which is called a pupil centroid shift, and it should also, machine ideally should be able to understand and compensate for all these. So what is Contura? You're removing glasses, which was the basics. You're also treating corneal irregularities because you're doing a topo-guided treatment. It's centered onto the visual axis, so it's right where it has to be. It's not on the apex of the cornea, and therefore it gives you a good vision. There are certain guidelines which are set up by the company, which tend to blur as you do more, and you tend to realize that you can play with this a little more. And this is to show you a before, and this to show you after of the same patient. It's a very pristine cornea, very well balanced. The entire ablation profile is centered onto the pupil, and it's a very, very clear situation. That was a myopic LASIK. Now this is just to show you a hypermetropic, and hypermetropes are a big, situation. Whenever these patients turned up into our clinic, the amount of chair time that they take and the amount of investigation they take are huge. So this is the refraction. This is a close cycloplegic refraction, high hyperope. Everything else looks stable. There's a little bit of astigmatism. Again, everything unremarkable. But notice, so I did a contour on this patient and noticed post-operatively, if you can see a bump over here. So what essentially a hyperopic LASIK will do is it will take out a whole donut-shaped button from this area, so as to dissociate the central cornea from peripheral cornea, and it will bump your central cornea so that it becomes like a lenticule in the center. So this is before and this is after the same eye. This patient is now settled down with minus 0.75 and a minus 0.5, which is fairly good outcome, and I hope this patient doesn't decompensate, because post-atropinized also the patient was at a 5.5. But it goes to show you that these lasers can not only treat myopia and astigmatism excellently, but these topo-guided treatments can also treat hyperopias quite nicely. The only difference I do is in hyperopic LASIK, as I was told by one of the senior engineers, Ankur, is don't do it on the patient's visual axis, but try to do it on the center of the cornea, and I do value that point. So this is just to show you the data. This is a company slide, but to show you that in patients who the study did Contura vision or topo-guided treatment, 60% patients were there at the same vision that they were seeing with glasses, but more than 30% patients saw one line or better in their vision as compared to their preoperative best-corrected spectacle vision, which goes on to say that if you treat the patient's higher order aberrations and do all the minor details of doing it at the visual axis and keeping it centered, if the patient's resolution capacity is high, you can be able to make them see better than what they were regularly seeing with glasses. And obviously this goes for all sorts of vision, daytime, nighttime vision, reading, computer vision and whatnot, because it's a truly customized treatment, you can see better. There are many studies that have proven that topo-guided treatment gives you better visual outcomes. And I'm not going to read this in the interest of time and to save something for Dr. Bhaskar to talk about. Just going to finish off saying that if you look at topo-guided treatment, this is an age where everything is changing. The whole world of refractive surgery is changing into lenticule-based surgeries. But what we need to understand is the primary reason we are doing a surgery for patients is for vision. And when it comes to vision, if the more crisper you can treat, the better the patient's vision is. So in my hands, topo-guided treatment or Contura vision works favorably, and almost all patients are very happy and comfortable within 24 hours of surgery, and most patients see more than one line at the end of the day. Thank you.
Thank you so much, Samresh, for taking us through this topo-guided femtolastic technology. So I think in the interest of time, we'll take the questions at the end. It was a very comprehensive, fantastic talk. And the next talk is also going to be a continuation of the same, which is going to showcase the evidence of the current topo-guided treatments. This is done by Dr. Bhaskar Srinivasan from Shankar Nethralaya. He is at the forefront of both ocular corneal disorders as well as ocular surface and refractive surgery as well. So over to you, Dr.
Good afternoon, one and all. And I would like to thank the AIOS organizing committee for giving me the opportunity. Quite a bit of it has already been covered by Samresh. It's not, yeah, sorry. So when you're looking at conventional LASIK, which is still the primary way that we would treat most patients, but then if you have to customize it, you could look at asphericity-based treatments, you could look at wavefront-based treatment, you could look at topography-based treatment, or corneal aberration-based treatment. In terms of topography-based treatment, Contura is probably the most commonest platform that is being used, even though you do have with the Cirrus and in combination with the Schwein giving you a corneal aberration-guided treatment as such. When you look at the advantage of topography-guided treatment, obviously you can treat irregular corneas, you can try to improve the corneal shape, it can capture and treat the patients on their photopic pupil. But the disadvantage is it ignores the complete refractive situation as far as the eye is concerned, and when you are correcting something extra on the surface, that could change the refractive endpoint. And this was the reason that when it was initially launched, it was primarily meant to be a repair station where you could treat unhappy patients, you could treat irregular astigmatism, you could treat them to enlarge the optical zone, you could treat decentered ablations as such. It's only recently that there's been a lot more of interest in treating virgin eyes because we've started understanding what treating these additional higher order aberrations on the surface does to the refractive outcome, and then we try to tweak our manifest refraction to end getting a better result. So when you're comparing a wavefront guided with a topography guided, obviously topography guided is pupil independent. It tries to create an ideal corneal curvature, and highly irregular eyes, you might not get good wavefronts, but you might still be able to get a good topography to correct them. This has already been mentioned by Samresh, where we capture the data and feed it into the machine, and you need to treat both the clinical refraction and add on to the higher order aberrations that the surface has, which needs to be corrected to improve the quality of vision that the patient can get. So when you're looking at the virgin eyes, the FDA approval was based on certain principles that yes, you would treat it if the treatment to correct the higher order aberrations induced is removing less than 10 microns of tissue, if the difference between the topographic axis of astigmatism and the acceptance axis is less than 15 degrees, and if the difference between the magnitude of astigmatism is less than 0.5 degrees. In an ideal world, you tend to have variations, and then you're not sure whether you would want to do a topography-guided treatment or you would want to do an optimized treatment, like in this example where the astigmatism magnitude is high, but the other two parameters are correct. So here is where actually when the first papers on topographic guided treatment came in, David Lin mentioned about topographic neutralization techniques, where he said you initially put the value in the modified column as 0, try to see what the laser is doing to correct the surface, identify any cylinder that it is inducing, add on the myopic treatment for the hyperopic correction that is induced by the laser, then add on the manifest refraction and adjust it. Unfortunately, at that point of time, people felt it is too complicated and it never took over. The other way of doing it at that point of time was to look at the central ablation that your optimized treatment would do, and you just tweak the refraction in your topographic modified way to kind of match the central ablation depth that an optimized treatment would give you. But these were still a lot more hit and miss kind of a situation. So now we do have certain guidelines on how we would want to do the treatment. You could either base it on manifest refraction, you could base it on what is called as a topography modified refraction, you could do a partial TMR, or you have the 4CD's analytical software to be used in certain situations. So the most important step in doing a topography guided treatment is to get good, reliable image. Garbage in, garbage out. If your topographic images are poor, no point in treating the patient with that. The next would be, if you're going to be treating it on the manifest diffraction, like in this patient, the ablation was less than 10 microns difference for a zero ablation. The degrees of difference between the topographic and the acceptance was less than 15 degrees, but the amount of astigmatism was more. Here, we went ahead with just correcting the patient's acceptance astigmatism of minus 1.5, and the patient did well. If you're doing a TMR, you would actually correct the astigmatism of the patient in terms of axis, correct the astigmatism in terms of magnitude. And the difference in astigmatism between the acceptance and the topographic, you would try to add on or correct the spherical equivalent of that to the manifest refraction, and that would be your final correction. Whereas if you're doing a partial TMR, you would probably just use the axis and the magnitude of the cylindrical correction without doing the spherical equivalent. So in this patient, in this example, you have a 2 diopter cylinder in your manifest, and you have a 3 diopter cylinder in your acceptance. So here you're going to be treating a 3 diopter cylinder, but that 1 diopter cylinder which you're treating extra, you will kind of compensate by correcting it with the spherical equivalent. The idea is to kind of make sure that your spherical equivalent of your correction that you're putting is almost the same. So here is an example where the refraction was minus 1.5, the measured was around 2.7. Ideally, we would have probably done a 2.5, but the treating surgeon was a little bit conservative, didn't want to go the full extent with the refractive cylinder and treated a 2. So the difference of 0.5 was corrected by a 0.25 adjustment in the spherical component. Another patient where you have a cylinder of minus 1.75, the topo cylinder is around 2.6, where we corrected amount 2.25, and the difference is adjusted as far as the spherical equivalent is concerned to give you a good outcome. And in this patient ended up with a 6.5 vision in both eyes. So you also have this paper, and you have a link to the Excel sheet of this in this paper, where you can feed the data in terms of a clinical refraction, your measured refraction, and it tells you whether you can go ahead with a topography guided treatment or you need to exert caution. The points for caution would be a cylindrical difference of more than 1 diopters, an axis difference more than 5, and here it is actually averaging the difference between the topo and the manifest refraction in terms of the cylinder, and it tries to maintain your spherical equivalent. So you don't have to really calculate by yourself, you just feed the data, the Excel sheet gives you the value. So here the cylinder is 1 diopter difference, and it says yes, you can probably correct it. Just a minute. And here when the difference is more, it tells you there is a warning sign, it tells you that maybe an optimized treatment would be there. These are again areas which are blurred because our understanding is improving and we are probably able to correct it better. You also have the 4C's analytical software which takes into account the posterior corneal astigmatism also and adds on that to your treatment algorithm. So this FDA approval, Samresh had already mentioned that about 93% patients had better than 20/20 vision, and almost about 30% patients saw better uncorrected visual acuity as compared to their preoperative spectacle corrected visual acuity. And if you're looking at best spectacle corrected visual acuity post-operatively, almost 40% patients gained one line better. The quality of vision definitely makes a difference with respect to a topography guided treatment as compared to conventional treatment. So it's as good, if not better than conventional treatment, lesser visual complaints, higher number of eyes, achieving what we still label as 20/20 vision, but it's an evolving algorithm. You need to spend a little bit of time planning these procedures. However, not all candidates might be a good candidate for a topography guided treatment. Thank you.
Thank you very much for taking us through, especially the evidence of the topo-guided treatment, Dr. Bhaskar Srinivasan. And in the interest of time, we'll go to the next talk, which is going to be by Dr. Diksha. She's going to speak to us about surface ablation, basics, types, and current evidence. And a kind request to stick to the time so that we can finish the session on time.
Good morning, everyone. I would like to thank AIOC and Professor Vanati to allow me present here. So I'll be talking on advanced surface ablation, basics, types, and current evidence. So Excimer laser for corneal tissue ablation was first used by Turboeda in Dutch rabbits. He used krypton fluoride gas Excimer laser. And eventually, after multiple human clinical studies, this was the first refractive procedure to receive an FDA approval in 1996. Currently, we have various variants of of surface ablation, which include conventional PRK, laser subepithelial keratomeliosis, epi-LASIK, and transepithelial PRK. So theoretically, surface ablation has a pro over the more popular LASIK because in this we measure on surface and treat on surface. Whereas in LASIK, we measure the corneal surface while we treat under the flap, which can lead to a discrepancy. But however, the popularity of the surface ablation had decreased because of postoperative pain and haze, but besides that, surface ablation is still preferred over LASIK in cases of thin corneas where there's a risk of trauma, like the patient who are involved in contact sports or military personnel. When there are certain corneal surface problems, flatter or steep corneas where there can be flap-related complications, and in cases of enhancements and retreatments. So there are various epithelial removal techniques. Initially, these include mechanical debridement using blunt spatula, sharp blades or battery-operated brushes, or chemical deepithelization using alcohol. In LASIK, the epithelium is loosened with alcohol and lifted like a hinged flap and replaced after stromal ablation. While in epi-LASIK, the epithelial flap is created with the epikeratome and then it is replaced. However, the latest advancement in surface ablation is a transepithelial PRK, which is a photoablative deepithelization where Excimer laser is used for ablation of corneal epithelium. So this transepithelial PRK was first described by Dr. Donald Johnson as a two-step procedure, where in the first step, epithelium was removed on PTK mode, and in step 2, stromal laser ablation was done on PRK mode. Whereas now, the single-step trans-PRK mode is also more popular, where epithelial removal and stromal ablation is done in a single ablation profile. The advantages of this transepithelial PRK is faster epithelial healing, faster visual recovery, less pain, and less haze compared to alcohol-assisted conventional PRK. So a brief introduction to the lasers used for stromal ablation, that is 1923 nanometer argon fluoride is the laser used, and the ablation depth depends upon the magnitude of refractive error, diameter of optical zone, and it is calculated using the Muller-Lins formula. So the size of ablation zone has remained to vary from 3.5 millimeter to 9 millimeters. Initially, there was small optical zone which were associated with postoperative halos and night vision symptoms, whereas the current larger optical zone are associated with faster visual recovery, have less visual halos and night vision disturbances, but are associated with increased tissue use. So a brief introduction to three popular types of wavefront three popular laser ablation profiles, which are wavefront optimized, wavefront guided, and topography guided. These have been discussed by our previous speakers. So I'll be skipping this part. The corneal topography, the concept of topo-guided LASIK can also be applied similarly to the topography guided surface ablation, where the surface is, the image of the surface is captured, and the laser ablation can be customized according to the findings of the surface. So the specific treatment of topography guided treatment, especially surface ablation is in cases of irregular corneas, especially after decentralized ablation in patients with fluctuating refraction. And it has also been used in virgin and pristine corneas to bring out better visual outcomes. However, because of these good results, the topo-guided PRK is gaining popularity even for normal corneas and is being chosen as one of the first-line treatment for many cases. So there are two gross categories of topography-guided surface ablation. One is topography-guided treatment, where the ablation profile is created to regularize cornea, along with manifest refraction is included into the profile to correct the both. Whereas in topography smooth, in eyes that have irregular surface, it can be done in a two-step procedure, where in the first step, the surface is regularized, and in second step, which is like 4 to 6 weeks later, the refractive correction can be done. However, there are certain theoretical concerns with topography-guided treatment. One is that the higher-order aberrations of cornea usually are compensated by similar and opposite internal higher-order aberrations. So treating the corneal aberrations alone may lead to unmasking of the compensatory internal aberrations that may now manifest and bring about a decline in quality of vision. However, clinically, the outcomes of topography-guided treatment have remained good. So we at our center use MEL90 for topo-guided treatment. In this, the patient's eye is imaged and analyzed by the Atlas topographer. The data is, the ablation profile is calculated on the CRS master, and then the MEL90 or MEL80 Excimer laser then automatically adjusts the laser profiles to match this planning. And for the refractive treatment, we use the advanced ablation algorithm of MEL90. So here I would just like to show a brief video of topography guided treatment. This is the preoperative epithelial mapping, where you can see the central epithelium thickness is around 55 millimeters. So in the first step, we remove the epithelium at PTK mode, where the laser firing frequency is 250 hertz. So we can adjust the depth depending upon the epithelial thickness. So in this case, we have taken 57 microns, and we can take +2 to +3 of what the current epithelial thickness is. Now epithelium has been removed, and now the appropriate refractive correction and is added, and the cornea is then fired for I'm sorry, this will move ahead. Okay, I think I'll skip the video. Besides that, we have conventional ablation profiles were basically based on the Monerlin formula, which correct the sphere and cylinder alone and are associated with higher introduction of higher order aberrations, whereas the newer aspheric ablation algorithms have smooth transition zone and they minimize the introduction of higher order aberrations. So typically, a normal human cornea is prolate with a positive spherical aberration of around +0.27 to +0.3, and surface ablation for myopia leads to central flattening and hence an increased positive spherical aberration. Now in this is the preoperative scan, and this cornea has a spherical aberration of +0.2. Now this is after a central treatment, the aberration has increased to +0.6. So this is the reason for the nighttime vision and the halos in the patients, and hence we aim for larger optic zones so that in the dilated pupil, patients do not face these difficulties. PRK is also popular as a retreatment option, especially after PRK, after LASIK, as well as after SMILE. And these are the various complications which have been already discussed in the previous slide. So to conclude, I would say that higher success rates with newer ablation profiles, decreased pain incidence, faster visual recovery, tissue-saving technology, and since it is bladeless and flapless, all these features make it a popular choice as a first-line procedure for refractive correction. Thank you.
Thank you very much. Yes, thank you. It was a very nice, comprehensive talk, Dr. Diksha. Thank you again.
Thank you.
And now we would like to go to the last talk of this session, which is on the post-LASIK refractive errors and enhancement techniques. Dr. Himanshu Matalia doesn't need any introduction. He is doing some of the phenomenal work in Narayana Netralaya, and of course, his talk on enhancement is always extremely full of pearls. I'm sure you're going to learn a lot from him. Over to you, Dr. Himanshu. Thank you.
Thank you, Vardman. I'm going to talk to you very basic talk. Starting with an example, one new LASIK surgeon, one of the glaucoma persons went out for the practice and gives me a panic call that I've done a myopic LASIK for a regular patient, and now post-operatively patient is -1 sphere in right eye and 0.75 in left eye. When do I do enhancement? Well, what I did? Well, I did nothing. I actually did cycloplegic refraction. Right eye was 0.25. Left eye was emmetropia. I reassured and sent the patient back. What we were dealing with spasm of accommodation. Well, so we should know that there are 6 major causes of post-LASIK refractive error, namely deliberate or non-deliberate undercorrection, spasm of accommodation, progression of myopia, long-term regression, cataract, and post-LASIK ectasia. I've kept the decentered ablation aside because it's totally different ballgame. Starting with deliberate or non-deliberate undercorrection. Well, before we go to that, there are certain investigations which are mandatory when you're looking at post-LASIK refractive error. One is unaided vision, cycloplegic refraction, which is absolutely must, a good slit lamp examination, corneal topography, axial length, and anterior segment OCT. So coming to, again, deliberate or non-deliberate undercorrection, typically the presentation is immediate. First post-op day, the vision will be poor. Now, if you do not have the surgical data with yourself, if you have, it's your own patient, go back and check whether there was a mistake in entry or anything like that. If you do not have data, well, you can ask patient, how was the vision on day 1? And many times patient may say that, well, vision was not so great. How do you manage? First, do a good cycloplegic refraction to confirm the refractive error. Second, if it was a deliberate undercorrection, do not jump over with the treatment. Find out the cause of deliberate undercorrection and then only go for that. Do an ASOCT, calculate the bed, calculate flap, Think about it. If it is safe for the patient, you surely can, as previous speaker said, you surely can go ahead with PRK and you should be fine. Second cause, spasm of accommodation. Typically, the presentation can be from days to months. Typically, the good vision on day 1 is norm. Usually, they do not have such kind of spasm immediately on day 1. Later on, when they start work, later on, the computer work, reading, and all those kind of things can possibly lead to these spasms. Near vision usually is good because of pseudomyopia. They are usually type A personality. How do we treat them? Well, reassure the patient, reduce the screen time, do a cycloplegic refraction, and if it still doesn't break the cyclospasm, you may have to atropinize these patients, and usually they do well. Third is progression of myopia. We all know this is the commonest side effect of myopia, which progression. Now, typically it presents from months to years. Good vision day 1 month, and all these documentation are required and depends upon natural growth. It would stop progressing. But the most important part here is your pre-op investigation. If you included axial length measurement, well, you can claim that there was a progression of myopia. If you do not have this thing, unfortunately, you have to take a blame and call it something like long-term regression. Many times, long-term regression, which presents from months to years, has good vision on day 1 month, very slow progression, and it's diagnosed on topography where the curvature bounces back or regresses. Practically speaking, I strongly believe it does not exist. I'll give you the reason. It's highly misused terminology when you're not documented pre-op axial length, and when you do not document progression of myopia, you end up calling everything as a regression, which is actually not true. By regression, we should be documenting change in keratometric values, and which is air-tear interface. Please do not confuse it with myopic progression. Now, George Aliev's group has published a long-term data, more than 15 years of follow-up from -6 to -18. I don't know how they did -18, but interestingly, what they found was the change in K value in 15 years was not a diopter also, which translates to 0.06 diopter K value difference in a year, which is actually not true. Now, interestingly, Dan Reinstein's group, well, again, we like to call that it's basically epithelial hypertrophy which leads to regression. Now, Dan and Reinstein's group has worked on, in fact, we also done our studies, but some other day we can talk about that. What Dan Reinstein told us that, well, change in epithelium usually occurs first 3 months, and later on it becomes stable, and which remains stable for pretty long time. And we know that myopic regression is not 3 months. We usually call it much longer. Again, similarly, there are other papers which showed that even long-term, irrespective of moderate, low, high myopia, irrespective whether it's PRK or LASIK, the change in K value is hardly much. So K value remains stable. Hence, if we have not documented all such kind of thing, we love to take blame. And then we have to say sorry, just because we did not document the axial length measurement preoperatively, and hence we have to cut a sorry figure. So all we need to do is do a proper pre-op workup. Now, cataract, 5th cause, which usually is much later. We know that it directly reflects into poor quality of vision. There is no change in axial length, there is no change in topography, and it can be documented by a good slit lamp examination, or even some of the aberrometers can actually document the presence of cataract. The last but not least, something which we all dread of, which is post-LASIK ectasia, usually presents many years or many months later on, typically asymmetric presentation, more in one eye than other eye. That's important to document your day 1 day 1 vision, 1 month topography, later on topography, to claim that you did not have these things pre-existing. It's usually compound myopic astigmatism, and the best corrected vision is usually less. Your elevation-based topographer shows posterior elevation, and that's very important sign of post-LASIK ectasia. Whenever your posterior surface starts showing elevation, well, you are dealing with ectasia and nothing but ectasia. Treatment-wise, they all need immediate cross-linking. The visual rehabilitation can be done by using intracorneal ring implants, or you can do topo-guided PRK. Overall, with all these things, we still have to remember there are 6 causes of post-LASIK refractive error: deliberate or non-deliberate undercorrection, spasm of accommodation, progression of myopia, long-term regression, which is debatable, cataract, and post-LASIK ectasia. Thank you very much.
Thank you, Dr. Himanshu, for a wonderful talk about the post-LASIK refractive errors. Due to lack of time, I will conclude the session here. I'll just invite the speakers just for a quick photograph, if we can come up.